welcome you all to the panel, a very interesting panel on fertility preserving surgery in rare gynec cancers. And it's a rare, yet it's an existing entity. So before I move on, we just require to all of you, all the panelists, to adhere to the guidelines. Please, because of shortage of time, we have to rush through many cases. We have got very interesting cases, almost 5 to 6 in numbers, and we want to complete them in time. So be very brief, precise, and come to the point. So around 1 in 25 cases of rare cancer survivors are seen in the young reproductive aged women, out of which 12% have got fertility issues. And the quality of life factors in the cancer survivors, as you know, is fertility preservation in premenopausal women, which is a high priority. So does this hold true for rare gynec cancers? And the challenges faced are, there is lack of data on rare gynec cancers, and there's anxiety about the fertility preservation options in both parties, that is the couple and the doctors. And of course, there's a compromise oncological outcome. And as you know, we have got the cancer incidence in infertile women is due to unopposed estrogenic environment. So therefore, you may need to remove the ovaries, you see. And if you remove the ovaries, then what will be her fertility status? So to answer all these questions, we have got a brilliant panelist from ranging from a team of gynae-oncologists to radiation oncologists to medical oncologists and of course radiologists, all before you to answer all your questions. You are free to ask any questions, any doubts, and I think at the end of this session, you will have all your answers. So coming to the first case. So Mrs. X, a 34-year-old lady, has come with the complaints of primary infertility 2 years and with heavy menstrual bleeding for the last 2 years. So she had, in fact, undergone investigations for an infertility workup. She had undergone DHL, and on laparoscopy, they had encountered on a right enlarged polycystic ovary, 10 into 10 centimeters diameter, which was adherent to the POD. The bilateral tubes were dilated, and during removal of or cystectomy, there was an inadvertent intraoperative rupture. Histoscopy also revealed a 0.5 centimeter endometrium polyp, for which polypectomy has been done. Now she has come with the reports of adenocarcinoma of the ovary, endometrioid type. Grade has not been mentioned, and there was no histopathological report about the endometrial polyp. So coming to the menstrual history, her obstetric history, menstruality was normal previously, but she had abnormal uterine bleeding for 2 years. She was a nulli gravida, and we go to the examination where everything was okay, except that per speculum, per vaginal, rectovaginal examination revealed that uterus was normal side, but it was deviated to the right with a little restricted mobility, and there was a cystic mass in the right fornix. Rectovaginal examination was normal. So what next? So I just put this question to my colleague, Dr. Bhagyalakshmi Naik. So what will be your workup in this case?
Thank you, madam. I think it's already we have the biopsy of the tumor, which is endometrioid adenocarcinoma, and about the polyp, I think we still don't have any, the biopsy has not been done, or maybe we don't have the biopsy report with us. So these are the two things which I will need, and the endometrioid, that biopsy needs to be reviewed again. But then this has already been a mishandled case, so the endometrioid tumor has already been, there has been a lot of contamination into the peritoneal cavity. And maybe I will do the markers, do a good imaging to see whether there is any other metastasis to any other side, and we'll need to do the markers, and of course the biopsy of the polyp in the endometrial
rightly
cavity.
we did all the markers, and we found that there was a rise in the CA 125 of 860, CA 1990 143.4, and the rest of the almost were normal. AMH was 2.1, and the slide block review revealed endometrioid adenocarcinoma. Of course, grade was not mentioned. It was, It was W21 negative, P53 negative, but estrogen and progesterone receptor positive. And the CECT of the whole abdomen pelvis showed a heterogeneous enhancing solid cystic lesion of 7 into 8 centimeters with multiple septa and loculations. So I would request Dr. Sonia, who is a radiologist, to please interpret these pictures of ultrasound and CECT.
Thank you, ma'am. We have been provided with images of ultrasound, transvaginal ultrasound, and contrast enhanced CT in axial sections. We can see that there is a complex solid cystic lesion in which is predominantly in the right adnexa, which is displacing the uterus towards the left. The endometrioid tumors generally present as cysts with enhancing mural nodules. We have to review the CT to ensure look for the presence of ascites, any enhancing peritoneal deposits, and the status of the uterus and the other ovary to plan the further management.
Thank you, Sonia. So now, some references we have for your information. That it's from American Society Journal 2009, and they say that ovarian and uterine conservating surgery were safe in young women who had stage 1A and 1C epithelial ovarian cancer. So now, regarding this, next. So what next? Dr. Shalini, what would you like to do?
Yeah, I think most
We
of
of course did an endometrial
has
aspirate
been
with people.
decided by the adenocarcinoma or endometrioid adenocarcinoma of the ovary that was mismanaged initially. You have a lot of spill. You did have tumor markers which were raised, which was 860 and 149.
No, we went in to do this endometrial aspirate with people, and we got an adenocarcinoma.
So now you have a synchronous
also.
tumor. You have a synchronous tumor. We normally call it synchronous when we find in endometrial biopsy for endometrial cancer. We look for a synchronous tumor, but here you have a report of something in the endometrium, which is an adenocarcinoma grade 3. Again, not a case for fertility sparing surgery, with a grade 3 and the adenocarcinoma report and your endometrioid adenocarcinoma. And what about the markers, the MSI markers?
Yes.
They were not done in the biopsy
In this case,
report.
I will not consider FSS.
Yeah.
Okay.
Till now, they were not done.
Okay, so supposing the patient wants a fertility sparing surgery, and we would advise because she is very young. So I will ask Dr. Vaidya, is there any role of ART in such a scenario?
Yeah, that's a very good question. The ART has a good role to play in this particular patient because she is a young patient with a good AMH, and the type of counseling that I will do for her would be embryo cryopreservation with and subsequent usage of the embryos in her uterus is absolutely ruled out because of the endometrial adenocarcinoma being found. But she will require to have a course to surrogacy or uterine transplant for furthering her family building. The factors that I would consider while counseling, pre-treatment counseling, would be that she has a good, though she has a good MH, though the BRCA status has not been mentioned, we normally do always BRCA status, and we always say the number of oocytes that would be harvested for BRCA positive patients will be less by about 30% than if she were to be a BRCA negative. That would be factored in, and that's how I would go ahead, that I will do an IVF. One more point that I would like to state, that at my center, both at Wadia as well as in my private, the referral to retrieval interval has been narrowed down from just 9 to 12 days, irrespective of the phase of the menstrual cycle and the type of the malignancy. We start stimulation right on the day 1 of the referral without waiting. Here, at least we have AMH. Though in Wadia, in my private also, we have our own labs, and we don't wait for AMH. We just go for one transvaginal scan and start the treatment. And I have got the slides just to show how we start in early follicular phase or late follicular phase or in the luteal phase, but that would be probably time may not permit it. But the take-home point will be the referral to retrieval interval does not exceed 12 days in any case, whatever be the phase of the menstrual cycle. So these are the points that I would consider in this particular patient.
Okay, so in this case, as rightly said by Dr. Shalini, so this was not a case for fertility preservation. So we had done a staging laparotomy with a parietal wash cytology, THBSO infracolicomectomy, and bilateral pelvic and para-aortic lymphadenectomy. And some resection, during section we got some deposits of the rectosigmoid which were removed, and the pelvic peritoneum were done. So as you can see, the intraoperative findings were again that there was a 12 into 12 solid mass adherent to the pelvic wall, and there were in fact deposits of 4 into 4 centimeter on the sigmoid colon, and very few deposits on the small bowel and also mesentery. But however, we reached an R0 resection, and the histopathology has come to that the right ovarian mass had a breach in the capsule, the right fallopian tube and the left adnexa were absolutely normal. And microscopic examination of was, in case of right ovary, it was grade 1 endometrioid adenocarcinoma, and same grade 1 endometrial adenocarcinoma in endometrium, and it had a less than 50% myometrial involvement. LBSI was absent, and here we got the IHC report as MMR proficient tumor. Pelvic peritoneum, of course, was involved, and others, omentum nodes were all free. So now my question to Dr. Vinita, what is the adjuvant therapy that you would prescribe?
Synchronous C ovary and synchronous C endometrium. As far as endometrium is concerned, it is a grade 1 disease. LVSI is absent, MMR is proficient. So it's a good biology disease. She does not require any radiation therapy and can go for systemic therapy directly.
Okay. So now to the medical oncologist, what type of chemotherapy would you prescribe? Anybody can take.
So, from whatever is given, it looks like a stage 3 ovarian disease because there are peritoneal deposits more than 4 into 4 centimeter. Is that what I understood from the presentation?
Yes, exactly.
So, we would give 6 cycles of paclitaxel carboplatin, and then if BRCA is positive, then they would get some PARP inhibitors as maintenance.
Right. Yes.
Yes, any
please.
difference of opinion?
No, I completely agree with my colleague. I'm only wondering about the various reports that we have got in this patient. The first report we could never get the grading, but actually it could have been reviewed at the same institute. Then the aspirate was grade 3, and then the final report has come to grade 1. So a lot of difference, though they are in the same institute. So that is my bit of a concern. Maybe we can go back, check.
Yeah.
I think that is something important, though I completely agree with the management part of it.
Right.
Okay.
So basically, this
one
test.
question?
Oh, right, sure.
The random start cycle that you would like to start, and these are ER/PR positive tumors, will those 10 days of high induction ovulation drugs will make a difference to the tumor in those 10 days, or it's okay, the medical oncologist will?
That's a very good question, and this we have been getting. The AR positive, PR positive has been already been circumvented by, we concomitantly start these patients on aromatase inhibitors, that is letrozole. We start letrozole in the doses of 5 milligram per day right on the first day of the stimulation, and letrozole in the doses of 5 milligram per day in 24 hours reduces serum estradiol levels by almost 97%. So our lookout throughout the this ER positive patient, whether it's a CA breast patient or an endometrial CA patient or this patient, wherever we get ER positive patients, we always start concomitantly letrozole 5 milligram per day for patient who is less than 60 kg, for letrozole 7.5 to 10 milligram for patients who are 80 and 100 kgs, that sort of thing. So aromatase inhibitors is a very efficient drug to curtail the estradiol levels. So the concerns about the estrogen-induced flare of the malignancy is well addressed by concomitant use of letrozole.
Thank you. So we quickly move over to the next case. Yes, you want
like to ask Dr. Razan. So interestingly, suppose this patient had a diseased ovary and one normal ovary. The AMH was within normal ranges. So suppose, because there is a post-operative diagnosis. So how do you decide, suppose the other ovary is diseased, so is there any chance you can still go for the fertility preservation,
Yes.
embryo preservation?
That's also a good question. As I understand from your question, the other ovary on the pre-operative imaging status is presumed to be normal. What are the chances of occult metastasis in the presumed normal ovary? They have been addressed in various trials to the extent of around 8 to 12%. And we factor that in when we, because ultimately the patient is going, as has been rightly put, the patient is at stage 3, and she is going to definitely go for surgical staging of this case. We tell the patient that this has a very, very small risk of upstaging the malignancy if at all, if I go for the transvaginal retrieval. And we tell them that if it gets upstage, ultimately however, it has been proved, such an upstaging does not ultimately affect the ultimate survival rate or recurrence rate of these patients. So these are all the things which are counseled to the patient, and then the patient addresses.
Rather than upstaging, I would like to know that suppose, getting viable good oocytes.
Yeah.
That is, I think that
Yes,
is more
yes.
of concern. And is there any chance that that might be a transmission?
Yeah, the physical presence of the malignant cells does not alter the oocyte quality. That is ultimately determined by the pre-treatment ovarian reserve of the patient. Because though we don't practice it in India, in countries like Japan, the in vitro maturation of the oocytes, at the time of laparotomy, they just aspirate the immature oocytes from the cortex of the ovary, which is already deceased, and still does not compromise with the quality of the oocyte. So I hope that answers your question.
So Dr. Vaidya, in this patient, in that situation, we are only looking at surrogacy, right?
Surrogacy and uterine transplants.
But
Uterine
this-
transplant. In this particular patient, transplant
Yeah,
is out.
I mean,
It
that's
is
what-
out, surrogacy
so
is
are
an
there
issue.
not laws changed for surrogacy in our country?
Yes.
So
that's
how
right.
is it going to help this patient? That is my question.
I was expecting this. The law has changed. That does not mean law has stopped surrogacy. In fact, the law has changed for the better. I have been doing surrogacy for last 18 years now. And I am really happy that the law has now in place for the candidates who are just candidate for surrogacy. The process has really eased out. We are now just in the final stages of surrogacy being legalized in India as per the Act passed on 26 January 2022, which safeguards the interests of the care providers, that is us, the care seekers, that is the intended parents, and the surrogacy, surrogate itself, most importantly. So surrogacy has not been outlawed, but it is more appropriately streamlined by putting the surrogacy rules in
Thank you,
force.
sir. Without any further delay, we'll move to the next case. Mrs. X, 27 years, Para 1, from Delhi. She has come with the chief complaints of lower abdominal pain associated with nausea, vomiting. Yes, this was the previous complaint for which she had undergone laparoscopy, RSO, right salpingo-oophorectomy at a private center. And the intraoperative findings which we found from the note were right solid ovarian mass embedded in POD, adherent to the posterior surface of the uterus, and there was an intraoperative spill also. And HP report which she had got showed a mixed germ cell tumor containing yolk sac and embryonal cell carcinoma elements. She was advised adjuvant therapy, chemotherapy, but she defaulted. She didn't take the therapy, and subsequently after 2 months, she again came with abdominal distension, pain and vomiting to us. What is the next workup for you, Dr. Biswajit? How would you work her up?
I think the first surgery was open, or it was the laparoscopy? It was laparoscopy. I think, still it's again a mismanagement, I'll tell. So as a routine, we need to review the slides blocks as we do in an institute. Number one. Number two, tumor markers, because we don't have a baseline tumor markers. Germ cell markers need to be done. And third is imaging. So I think she has got now upper abdominal symptoms, so CT abdomen pelvis should suffice.
Okay, so now she has got the slide block review as yolk sac tumor, and which was glypican 3 positive, CD30 negative. It was a mixed germ cell tumor. The CT thorax and abdomen. Thorax, there was a small 2 millimeter nodule in the apical segment of the upper lobe, and liver has a small hypodense patch, and there were lesions, large lesions, about 13 into 10 centimeter and 14 into 12 centimeter from the right adnexa. Mild ascites were there, and there were multiple deposits over the abdominal wall. A serum alpha fetoprotein was more than 60,500. So how will you manage now? This is a question to Dr. Shalini. Kindly answer. How will you manage this?
She's received 4 cycles of BP chemotherapy.
No.
What is your plan now?
What is your plan?
Yes.
No, actually,
She has
she's a
come to you.
full-fledged case for new adjuvant therapy, right?
Okay.
So how do we take this case forward now?
Yeah, so once you work her up and you see that there's extensive disease now, there's quite an extensive disease, if you can go back to that slide. Prefer to give her chemotherapy before operation.
So you won't go for a redo surgery. That is, you have to prefer a chemotherapy.
I would
first
prefer
chemotherapy,
chemo
Yes,
before surgery
definitely.
in this particular case.
So
yeah.
then
So now she's receiving 4 cycles of chemo.
she has received 4 cycles of BP, And now there is, on CT, there is complete resolution of adnexal masses. Omental and abdominal deposits all have disappeared. Only there is a small residual deposit of 2 into 3 centimeters in the right iliac fossa, and there was no bowel invasion with this deposit. Her AMH was 0.4, and the tumor markers have all come down. So next, Dr. Bhagyalakshmi. So what is your line of management?
I think since all the tumor markers are normal, so we could think that it could be some necrotic residual disease only. So I think we can keep her on follow-up only, because everything has.
Or would you go for an interval?
Interval debulking, interval surgery?
Because she has responded very well, everything has disappeared. So this is a chemosensitive disease. So actually it depends. I have to decide upon whether to do a surgery or not. It's not very clear then. But then I can take a call because all the markers are normal. So it could be some only a benign portion which is remaining.
Okay.
So
Dr. Bhavna,
I
what
think
is your
that,
opinion about it?
I think that we should certainly consider this lady for surgery.
have we done a PET scan for her?
No, we didn't do a PET
You have to
scan.
suggest.
Only
Okay.
CCT we did, and
Yeah.
it showed there was some residual disease there.
There was some
and her
residual.
markers have now come down to normal.
Yeah, we can do a PET scan just to find out whether it's some active disease or some maybe
Active
some
disease or
yeah.
not,
But
and then
still, I think we should certainly
Yeah.
consider this lady for surgery, because we have to decide whether there was only necrotic tissue or there is
Or it is
still
not.
some viable
Exactly.
disease, and then in that case she may require further treatment. So I think it is
okay.
important.
And before that, how will you counsel the patient, Dr. Vaidya? So she is going to undergo surgery.
In this particular patient, with the AMH of 0.4, she virtually has no chance of having her biological progeny, because the ovarian reserve is already in the range of premature ovarian failure range. Otherwise, just one more line, in this this sort of patients where ovary sparing surgery can be carried out, and then we can carry out the oocyte cryopreservation if she is unmarried, or if she is married, then embryo cryopreservation.
She was para-1 live one actually. Had
Para
a
one
3.5 years old baby
Yeah.
already at home.
With AMH of 0.4, her oocyte.
But it was immediately after post chemo. So do we expect some benefit of?
You can give her some agents to raise her IMH.
Yeah,
isn't
we
it?
normally wait for a period of 1 year and then
Yeah.
retest her AMH and
Yeah.
antral follicle count as well. The initial first indication of resumption of the oocyte recruitment would be resumption of menses if she has been rendered amenorrheic by virtue of chemotherapy.
So at this stage, probably will not do any cryopreservation, and
No.
we plan definitely for
Yeah,
a fertility
yeah.
preserving surgery for
Right,
her.
right.
Right.
So then surgery, yes.
Bilateral ovary is involved here.
Initially, yeah, first upfront, the bilateral ovarian masses were there.
Do the surgery, would you go and do a frozen, do a biopsy?
That's what is the next question.
Question. So intraoperative findings were one term studied with deposits. They planned interval debulking surgery, and these deposits were all adherent to the anterior abdominal wall. There were multiple tumor deposits on the right parietal wall. 3 into 4 centimeter deposit rising from the omentum and infiltrating the ileum 5 centimeters from the ileocecal joint. Uterus was normal. Left tube and ovaries were stuck to the posterior wall, and there was a small deposit on the bladder and a small deposit on the anterior wall of the rectum. So in this case, Dr. Shalini, what will be your extent of surgery, and is there a role of frozen section to see the residual tumor?
Yes, so we would be doing a secondary debulking. That segment of the ileum which is involved, you're going to remove that, and you said the ovary was stuck to the uterus, but then you'll have to dissect it out and see how the ovary is and send it for frozen section to see whether there's any residual
So we
tumor,
should
and
send
then
for the
decide.
frozen section
Yeah.
and decide whether we can leave the tissue, or is it just a fibrinous
Because
reaction?
removing the
post-chemo?
ovary is not going to change the course of the disease, or
Exactly.
removing the uterus, sorry, is not going to change the course of
Yeah.
disease. But if the ovary is involved, then you'll, it may have had a complete response with your chemotherapy.
Yes, ma'am.
Whether you
So
want to leave
any
it
opinion
or
from the pathologist on the floor, how much agreement does frozen section preoperatively or intraoperatively goes
This
with
kind
the
of a scenario.
post-operative
By
pathology?
and large, frozen section is accurate in about 90% of the cases. But this particular case, I'm worried you've already given chemotherapy. So she given a good response. Whatever a small biopsy or deposit over the ovary that you may send for frozen, if I see only macrophages, does that negate any other residual disease elsewhere?
Yes.
I think it will not. So, I mean, my answer may still be negative for malignancy, but the patient may still
But
have
it may.
malignancy. That is my worry.
Any other focus? Yeah, exactly.
Yeah, so one more point I want to make it here. Suppose there is a deposit over the ileum, or you need to do some extensive cytoreductive surgery with the normal tumor markers. The question is, invariably, most of these deposits, if you send, they come out as necrotic. So is there any point of going ahead with an extensive cytoreduction, or you can just debulk the tumor to the maximum extent possible and then come out?
So here comes the role of counseling of the patient and her relative. Actually, this was a real world problem we faced. Then in TROP, we counseled the relative, we spoke to him and told them that this is the residual, looks like residual disease, but then this is extensive. We still have deposits, but we're not sure whether it will have a disease or not. So leaving the other ovary and the uterus, and the husband decided that she was para-1, live-1, already a baby at home. So he decided to go in for a completion surgery. He said he doesn't want to take a chance because he had a tough time during that phase of his period where he had this extensive ascites and all those things. So I'll share the experience. We did a completion surgery R0 and the final histology showed no residual tumor anywhere. So this further reiterates the fact that yes, all malignant ovarian germ cell tumor, advanced or early, we have to have full focus on fertility preserving option. Yeah.
Okay, so next case.
That's a question from the panelists. We have August panelist here.
So if it is a bilateral ovarian masses and then after chemotherapy also she is having residual deposits which you don't know.
Yeah, ma'am is there. Ma'am is wanting to ask.
So what is your line of
yes, ma'am.
management?
This is a query. See, okay, you've done supposing, now here you did a complete surgery and it was all negative.
Yeah, exactly.
Okay,
everything was negative.
You had done fertility sparing surgery and the disease comes back, and as you've seen last time, the disease came back so badly and it comes back even worse state, and within 6 months, then where do you stand?
Exactly.
So I think surgery definitely remains a mainstay of treatment.
Yeah, definitely.
So before surgery, as Dr. Vaidya has said, we can do a ovum pickup and preserve those, cryopreserve. Later on, when she desires a pregnancy, we can.
With 0.6 AMH, maybe we won't be able to do anything, will we?
There are certain drugs which will.
Yeah, exactly. That's what
Certainly
even
not
I would
with
want to ask
0.6
Dr.
AMH,
Vaidya.
but we would like
Sorry,
to
sir?
certainly not with 0.6 AMH.
Yeah,
It
with
has to be
0.6
at
AMH
least
at this
0.9
point,
before
definitely
we
not,
start,
maybe.
yes.
Yeah, that's, I also
that's
wanted
the
to ask him thing. the same thing, that, with such low AMH, what are the chances of picking up an ovum and, subsequently preserving it and so on and so forth?
And I don't think any drugs which can improve oocyte pool. When it's 0.4, it's 0.4. It's no drug that can improve the oocyte pool.
There are all experimental stages.
So ART people are magicians, but not that big. I would say.
Okay, we quickly move over to the next case. Seema, please.
Yeah. So now we'll have. Sorry, ma'am. Yes.
Just quickly, is there any point in waiting if the AMH is so low? I'm asking Dr. Vaidya, if the AMH is so low, over the year, is it going to improve?
It does.
Very good question.
Yeah, it does.
Yeah. We have seen post chemo the AMH coming back to almost pre-treatment levels within a span of 1 year, because the oocyte pool, the amount of oocyte pool at any given time in the life of the patient is a genetically determined entity, not modifiable. It may be suppressed to some extent, but it will recover back after a gap of about 12 months.
Thank you so much. That's new for me.
Yeah, it does.
But,
Can I ask a question?
Leaving any disease behind, in the sense our oncological outcome must be assured first.
Exactly.
Fertility preservation is okay, but I think the life of that woman should always get a priority.
Yeah, very good message,
factored
Dr.
in the
Bhavna, that
counselling part of
oncological
it.
outcomes comes before the reproductive outcome. Yeah, there is no doubt. Yeah, please. Yeah, this is another option. Yes. Yeah, we can do that. Yeah.
Yeah.
Yes, absolutely.
I agree. Yeah.
And studies have been done. They have shown that uterine preservation had no adverse impact on oncological outcome. Yeah. Yeah, absolutely, absolutely. So we'll start with the sorry.
If this patient had a residual disease and she has completed already 4 cycles of chemotherapy,
yes.
My question to the medical oncologist is that after surgery, will you give more chemotherapy, and if yes, what will be the chemotherapy?
There was no residual tumor.
No.
I guess.
If there is a residual tumor, suppose.
No. There were residual
in
tumor
this case,
visibly. Okay, if disease is there. Okay.
If the disease is there, what is
Would
the
you go to
management?
what will chemotherapy or
Adjuvant, what is the role of adjuvant therapy in this setting if the histopathology shows presence of some tumor, right? Viable tumor.
Since the markers, assuming that they are normal, but if I find a viable disease on the histopathology, I'll give 2 more cycles of the chemotherapy.
Okay, right.
Same chemotherapy.
DP?
No, I'll give same chemotherapy.
Okay, yeah, okay.
So quickly.
So next we'll take to fertility sparing management in genital tract sarcomas, and we have 2 very interesting cases lined up for that. So she's a girl, 21 years old, college student who came to us with bleeding PV, discharged PV for last 8 months, and there was a mass which was descending per vagina. She had loss of appetite, weight loss and weakness. She presented to us with HB of 4.8. 2 units PRBC were transfused and she was kept for examination under anesthesia, where we found there was a large fleshy polypoidal mass which was arising probably from the posterior lip of cervix and also abutting the posterior part of vagina. Couldn't make out whether it is arising from vagina or it is abutting there and filling the whole vagina. So vaginal mass biopsy was done and which showed presence of embryonal rhabdomyosarcoma. Her CE, MRI and PET-CT images are shown here. Dr. Palak, you are here. Just explain the images to us.
Ma'am, the contrast MR images which are in sagittal, they are actually T2 weighted MR images. They're showing a large heterogeneous lobulated mass which is probably arising from the cervix and extending into the vagina. It is involving the posterior vaginal wall and we can see that it is abutting the anterior wall of the rectum posteriorly and the bladder anteriorly. The CT which is there in axial sections, the PET-CT, shows that there are some necrotic areas, but we cannot see any ascites or lymphadenopathy here. So there is no obvious parametrium that is involved in this.
There was none actually, no parametrial, no distant metastasis, no lymph nodes, nothing. We did a cystoscopy and sigmoidoscopy as well because the mass was big, it was abutting the vagina. So, but there was no invasion anywhere. So what next? Dr. Biswajit, for you, the question for you. How do we decide management now for this patient?
She is 15 years now.
So 21 years
21
old.
years.
Unmarried
and it's
college
a
student.
embryonal rhabdomyosarcoma.
Yeah.
Most probably coming from the cervix.
Yeah.
So embryonal rhabdomyosarcoma usually responds very well to chemotherapy. So personal experience, no, but as per my knowledge, I think we can give NACT and as per literature, it responds very well to chemotherapy, and then we can assess whether we can go for a fertility preservation. I think there is parameter is not involved and confined with the cervix. And the vaginal involvement, I think it's very, in CT or MRI, I think a clinical examination always takes a precedence over the others.
So you want to downstage the disease?
Yeah, I would like to downstage the disease with chemotherapy first.
So which chemotherapy regimen for Dr. We have Dr. Bhavna and Dr. Biswaji we have with us, like medical oncology? Yeah.
Any medical oncologist?
Please take the question, Dr.
Yeah, so usually I think I'll go for VSA, that is our standard choice. I think we can go for vincristine, actinomycin D combination for us, which is what we give. And most of these patients will respond well, as my colleague mentioned. You want to add something?
So is there any role of radiotherapy?
Pre-op radiotherapy in this kind of a setting, how do they behave with response to RT?
So this patient is just 21 years old and there's always a case for fertility sparing. So for her, I would not go for radiation upfront. If surgery has been done after chemotherapy and there remains a tumor with positive margin, we might think it over with a brachytherapy case in situ.
Later, okay.
Can I say something? The experience I've had with rhabdomyosarcoma in young girls, cervical rhabdomyosarcoma is very poor. Whatever you do, they recur, and I've lost at least 2 patients who are 19-year-old or 20-year-olds with rhabdomyosarcoma.
Yes,
so I'm not very sure about the fertility aspect.
So,
unless it's changed.
Embryonal rhabdomyosarcomas generally have a good prognosis.
Cervical? This was cervical. I was talking about cervical.
I think there are many factors except only for being rhabdomyosarcoma, how much was a necrotic and tissue, and they behave differently. We have had, I have studied literature
and the pleomorphic variants, I think they are more aggressive.
There are many other subvariants and many other factors to be considered. So in this patient, we gave her VAC and she had partial response. 1 into 2 centimeter mass was residual mass on the posterior lip of cervix. So what next? What are the surgical options, Bhagya ma'am? She has 1 to 2 centimeter residual mass, 21 years old female. How do we counsel and what surgical options do we give her?
Looking at the response, which has been really very good, We have an option of course, because we are doing all this for fertility preservation. So in case there is no other disease, we can think about a trachelectomy or
Okay.
a conization.
So trachelectomy is perfect. Any role of ovarian transposition, Shalini ma'am?
You're not going to use radiation. I don't know what the adjuvant treatment is going to be planned. There's
Radiation, should we think of something, I mean,
if
some
you're not going to
ovarian
use that, then there's
transposition,
no need
adjuvant
to-
therapy, how do we plan that?
If we have to plan radiation, then we would think of course, during the surgery of ovarian transplantation, that would be better, oophoropexy. And they actually transpose the ovary as in the paracolic gutters as far and lateral as possible. And then when we do radiation, we actually target the PTV, and the PTV to the of course the ovary. The centimeter gap between the two should be more than 2.1 or 2.5 centimeters at least apart. So then we can target that area. But radiation will be only offered if the margins are positive after surgery.
No,
Okay.
but this case, trachelectomy, as Bhagya said, it can be done. Before that, would you like to ensure some other parameters regarding a fertility status? Like AMH, of course, and
AMH, yes, of course.
about the male partner.
But she's unmarried, so at this stage of life, no, but then
she's
yes,
unmarried,
yeah,
yes,
she's unmarried. So right, adjuvant therapy only if her margins are positive, RT. And about chemo? More cycles of chemo or anything, or no, nothing? It was an embryonal rhabdomyosarcoma only. Post-operatively, it was like necrotic
histopath?
tissue was more than...
Should you go for staging, Bhagya, in this case, with trachelectomy?
No.
Staging lymphatic?
No, it doesn't spread by lymph nodes, ma'am. It doesn't, sarcoma, and ovarian involvement is also very less, very less chances of having her ovarian involvement. So we can preserve our ovaries, and in case we feel that margins are not possible, then we can think of having her post-operative RT. Okay, so another case, we have I think 5 minutes. Yeah, ma'am, there are varied presentations, patients extending from small tumors. Fertility preservation, yes, surgeries have been done for because these tumors occur in young patients. So every time you have an option of having a fertility preserving, and that led to the concept of neoadjuvant therapy for these patients, downstaging the tumor and going for even this conization, trachelectomy, and follow if hysterectomy, if at all it is not responding.
When the option of fertility preservation is considered, I would like to carry out at least one stimulation cycle prior to NACT. Because NACT would undermine
Prior
its
to
ovarian disease.
NACT.
Prior to NACT.
So that, do we have this much of time? I mean,
that's what
she's a huge
I have not
mass
completed.
and
If you give us
4.8
just 12
HB,
days, we can
yeah.
carry out. If it's just
Yes, sir.
12 days, then we can.
It'll be
Otherwise,
difficult, sir.
her life is more
Yeah,
important.
we
Yes.
won't like to wait, I think. Yeah.
Yes.
They do progress. Yes, ma'am. We had 2-3 cases where. Yeah. But the biology will be decided, like if she is not chemoresponsive, then of course the tumor has a poor biology, and in that case fertility sparing surgery I don't think anybody can employ. Yeah. Absolutely. Exactly. Yeah, absolutely, absolutely. So there's another interesting case which was referred to us with a report of low-grade endometrial stromal sarcoma of vagina in a surgically resected specimen. Patient has been infertile for last 11 years. Her male factor was normal. In 2011, she first underwent excision of vaginal mass, no biopsy. 2019, diagnostic hysterolapro with vaginal myomectomy and enucleation of perineal fibroids. It was reported as fibroids. In 2021, she again underwent a surgery, vaginal fibroid excision and enucleation of perineal fibroids, which was done elsewhere, and these pictures we got from the center, they gave us. Per op, there was right vaginal wall fibroid, 4 into 5 centimeters. The report showed low-grade ESS of vagina, CD10 positive, ERPR positive, and Ki67 was only 1%. So what further treatment could be offered at this stage for her? So Dr. Bhavna and Dr. Biswajit we have, yeah, medication. So we have radiation oncologists, medical oncologists. So we want to know what we could have done
So
at
it
this
looks
stage.
like low-grade ESS only because 11 years back also this was excised. The only thing which is not mentioned here is the margins. It is expected that the margins are not R0
They were
because
enucleated, yeah.
it is only enucleation.
Yeah, yeah.
Generally, there is scanty literature regarding ESS vagina, and we follow the literature of ESS endometrium. And by that, she should be getting hormonal therapy. But in case it is enucleation, margins are closed, I think additional radiation therapy should be given or revision excision.
So you want to give radiation therapy at this stage?
Along with hormonal therapy.
Along with hormonal
And
therapy.
she's not had ovarian oophorectomy.
Nothing was done actually from outside. So what we could have done, we just wanted to know, because why this question is, because she presented after some time to us with recurrence. So that is why we are asking that at this particular point of time, shall we ablate her ovaries? Shall we give her RT? Something should be done
I'm sorry,
at this stage
I
or
think I
not?
changed my mind now. She needs completion surgery first, including, I think, oophorectomy has to be done.
At this stage?
Dr. Seema and Dr. Jita, Dr. Seema and Dr. Jita, vaginal ESS is not there in the classification, WHO classification.
Yeah, it's a
of
very rare
tumors.
entity, yeah.
And there are only 8 cases reported worldwide. So
Yeah.
how are we talking about fertility preservation in this patient?
Ma'am, in...
they are hormone receptor positive, we are here.
Yeah.
And ovaries have to be removed or ablated. So in that case, she will definitely, if she wants a family fertility, can be done.
Only thing is that we'll have to co-treat it with letrozole because she is AR positive and then carry out the ovarian stimulation cycle.
So at this stage...
Just wanted to clarify one thing. Myself, Dr. Shweta from Varanasi MPMCC. So this vaginal ESS was post-myomectomy, right?
Post-myomectomy, right.
And it could have been very well of the uterine origin, which could have
No,
disseminated
uterine
through-
EA and everything was normal. It was an extra uterine and low-grade endometrial stromal sarcoma.
So the myomectomy which was done was through vaginal route at that time, 11 years back.
No, yeah, vaginal route only, myomectomy.
Nothing in
it
the
was a vaginal
uterus,
myomectomy
nothing
at
in
that
the
time
uterus, it's in
also.
the vagina. Myomas in the vagina, nothing in the uterus or cervix.
Vaginal myomectomy was done at that time also. It was not a uterine myomectomy, no
Okay.
abdominal scar, nothing. Only vaginal myomectomy. So it was an extra uterine low-grade endometrial stromal sarcoma.
Okay, thank you.
So the literature is sparse, that was the problem. But then yes, cases, whatever cases we have in literature, partial vaginectomy, local tumor excision, and these things have been done. And reporting is there that for certain point of time there was no recurrence. So that gives us some option in young patients. Can we think of fertility preserving in these patients?
So in this, I think in this case, the management of vaginal low-grade ESS, what Madam told, you can just extrapolate from the
Exactly,
uterine,
exactly,
ESS.
yeah.
And yeah, I think there are literature that ovarian preservation can be done, although there is a chance of recurrence is more.
Yeah, exactly.
So
Yes,
and usually in ESS, the recurrence is salvageable.
So
The
this
survival
patient
is
had-
not affected.
Yes. So this patient had a very strange recurrence actually. Just a second, let me complete first. And this patient, is, at that time, no ovarian ablation was done, no letrozole, nothing was done. And she was left alone. After 15 months, she presented with very strange pattern of recurrence. One tumor in the forearm, one in the ischiorectal fossa. I mean, they were all resectable, moving types. So, and see, this is a picture. And there was this one little vaginal thickening is here. And in this picture, this is the ischiorectal fossa tumor. So these kind of tumors, and there's nothing in the uterus, ovaries, nowhere. So genital tract, there's nothing. It's only in the extra genital, I mean, these areas. In these are the locations. And when we did the biopsy review and we repeat the biopsy from this place, and they were all confirmatory of low-grade ESS for this patient. So ovarian preservation in low-grade ESS, yes, it has been reported. But yes, there's increased risk of recurrence, as very nicely pointed out by the panelists. So what next? What we should do?
So now she is already 39, 40, what it looks like that to me. So most important thing is that how keen she is for the family still.
She was actually keen on fertility.
Yeah,
there is
yeah.
no doubt.
So another option could be, of course, she requires treatment. I mean, in the sense hormone therapy and all that. If she is really keen, then now that surgery, everything is done, maybe we can retrieve and plan for this. And then probably still require hormone therapy. There is no
Dr.
question about
Vaidya,
that.
shall we go ahead with the retrieval or something for her at this stage, because she's ERPR positive, low grade ESS? Just 2 more minutes. It's an important point to bring out.
Yeah, ERPR positivity, the most important determining factor apart from the oncological markers is the desire for fertility. She is keen on fertility.
She is.
And once the oncologists say that she is keen on fertility and you can go ahead with the cycle, we will definitely go ahead with the cycle. We require just 12 days. We co-treat it with letrozole and we will give her the realistic counseling of her what about your life expectancy and all those things. And in spite of all that, if she is willing for, because the restriction of life expectancy cannot be a determinant for not providing her with the fertility preservation option.
Yeah,
it is the overwhelming desire for her to have a biogenic progeny. That is what will be the determinant of her fertility.
We also thought so, and we reviewed the literature on that, and we found that this is not. We found one case report where one patient was undergoing IVF and she had a sudden extensive, kind of sudden enlargement of that ESS. So only one case report we found which showed us that yes, this patient was not diagnosed case. She was undergoing an embryo transfer and all those things, and then they found that some ESS suddenly cropped up in the uterus because of that. The only case report that I found in literature on this aspect. Otherwise, naturally, there's lack of data on this particular topic in this, because the low-grade ESS, highly hormone-responsive tumors, but definitely they are slow-growing as well. So we do not know what to do exactly in this case. Yeah. So
I think with the recurrence, you have to remove the ovaries now.
Yeah, we have to. We have to. We have to now complete, because she's a recurrent setting. Had she been in an upfront setting, we could have thought of something, but not now. Exactly.
Multiple recurrences also.
Multiple recurrences.
Over the years.
Also diagnosed recurrence is only one, but then yes, there are multiple
She
recurrences.
did not get letrozole or any other treatment once ESS was diagnosed also.
Yeah, right? Now it's nothing. And last case, but very short.
The shortage of time.
There's a case of recurrent molar pregnancy who had 2 partners, and she had 2 partners, and every time she had a mole with both the partners. So this was a 3rd molar pregnancy for her. So the question here was the role of ART options for this patient. Is there any role of selection of oocyte or something in this? We just wanted to bring out this important point.
Yeah, I'll take this. The assisted reproduction technology coupled with pre-implantation genetic testing of the embryos is one of the most effective way of almost completely averting the subsequent pregnancy. In this particular patient with 3 genetic contributions from different males, still if she keeps on getting gestational trophoblast, she is an ideal candidate to undergo ART cycle with pre-implantation genetic testing of the embryos. What do we do in pre-implantation genetic testing of the embryos? One is the ploidy status of the embryos that are formed. As we all know, the complete GTNs are the duplication of the paternal chromosome with a lots of maternal chromosome. Once we have these embryos, we test them for the origins of because the blood samples of the parents have also been withdrawn, and if they match that of the father, a particular embryo which is screened as while carrying only the paternal chromosome with total loss of maternal chromosome will not be transferred into the uterus. Another mechanism that leads to gestational trophoblastic neoplasia is a polyspermy. That is the partial identity formula. That is obviously ruled out because the sperm will be, in ICSI we use only one sperm. So polyspermy is totally avoided at that stage of impregnation itself. And the other way to avoid this ploidy by screening them. So by screening the embryo for the ploidy status, and of course the this is a very ideal candidate to undergo IVF cycle with pre-implantation genetic testing of the embryos to completely avoid the future gestation with gestational trophoblastic neoplasia.
Right. Thank you. So with this, we would like to thank our panelists and also our audience and the organizers for giving us 5 extra minutes. Thank you.
Thank you. Thank you. That was a wonderful panel discussion. But something which we shouldn't forget is that oncological safety should be first. And one more thing I wanted to comment is, when do you really transplant? Because do you really wait for those window period of 1 year, 2 years, which is a high chance of recurrence before any transplant and things? So do you want to comment on that?
The decision for the transfer of the preserved gamete, cryopreserved gamete or embryo, whatever, is always in joint consultation with the oncologist. And because as you rightly said, the life of the patient is at utmost importance. And that is why I always said that ART consultant should always be a part of the tumor board discussion. And even if they are working in the private and they are willing to volunteer their services just for the sake of furthering the knowledge, at least particularly on my part, I'm ready to do it. And the decision to transfer the embryos will be taken in consultation with the oncologist, with the social worker, with the discussion, with the 3-4 people will be involved. When we ultimately, it is not that the ART consultant alone decides when to transfer the embryos.
One more comment I need to see, because this is practically we see they would have preserved their embryos, post they have a recurrence, and there is a dilemma of what do they do with the preserved embryos. So all these are problems in the real world situation when they have a recurrence and the embryos which are preserved are still in the
yeah. At the stage of cryopreserving the embryos or the gametes, it is the standard practice laid down by our rules as well as ethically that we address these issues, and the consent is foretaken in case of eventuality on the part of the that is either death or inability to transfer, what to do with the embryos, whether they should be allowed to be destroyed or whether they should be given for the research purposes. So these are the things which we have already forecounseled. We have a very good counselor who takes care of, there's a joint decision being taken with the party involved, what to do with the gametes or surplus gametes in case of the patient either medically unfit to undergo transfer or not available for transfer.
Okay, thank you. We'll wind up this session.
Thank you all.